Good afternoon, and thank you for allowing me the opportunity to discuss the importance of networking during a global pandemic. I have no financial relationships to disclose, nor will I be discussing any off-label or investigational uses of any medications or medical devices today. In March of 2019, Chinese authorities had alerted the world of dozens of cases of a pneumonia of unknown cause. Over the course of the next few weeks, this mysterious virus was identified as a coronavirus, but it was found that it was different than SARS and MERS, which we had seen in the past. Over the course of the next few weeks, China had reported its first death, had confirmed person-to-person cause, and it had been noted that this new novel coronavirus had been detected in other countries throughout the world. Because of the speed at which this novel coronavirus was spreading, early information sharing was paramount. Early days of information sharing included personal contacts. As we prepared for the onslaught of patients in the ICUs in Chicago and other cities throughout the United States, we looked to our colleagues in heavier hit areas of the world, including China and Italy, for experience sharing of what they had seen with their patients with coronavirus, where they were working in their ICUs. We also utilized professional contacts, such as email groups, or online communities, to be able to share experiences taking care of these patients. One such email network had a variety of different topics discussed, and on the very first day after its foundation, various topics came up, including care algorithms for the patients within our ICUs, response plans, how to staff our ICUs. In addition, there were many discussions based on how to care for these patients with ARDS. Are we proning these patients? Should we be using high PEEP? Are people going to place these patients on ECMO? Over the course of the next few weeks, this email network came up with other topics of interest, including how are we oxygenating and ventilating our patients? Are we using helmet ventilators, non-invasive ventilators, high flow nasal cannula, or even APRV settings on the ventilator? We discussed how to best take care of patients when we are overwhelmed in our ICUs. We discussed converting operating rooms into ICUs and cohorting patients within special areas of hospitals or within special hospitals altogether. In addition, we talked about how to take care of the patient's other comorbidities, including using RRT for renal failure. We discussed patients' anticoagulation strategies, and we discussed how best to sedate and paralyze these patients for compliance with our ventilator settings. Another aspect in order to allow for early education and early experience sharing was the use of social media. One such media was the use of Twitter. Early on in the pandemic, there were multiple hashtags that were created to discuss this type of information, including COVID-19, SARS-CoV-2, coronavirus, and COVID. As time progressed, we were actually able to share additional educational sources via MedTwitter, COVID Foam, or COVID Foam Med. And we also found that over the course of time, Twitter was a helpful way to educate our public by using hashtags such as flatten the curve, slow the spread, wear a mask, vaccines save lives, among others. Another social media site that was particularly helpful for early experience sharing was Facebook. In early March, multiple different groups on Facebook were formed to be able to educate healthcare providers about coronavirus. This is just a small smattering of all of the potential sites that there were. The first two sites there actually had membership of up to 30 to 40,000 physicians and healthcare providers sharing information. And some of these sites are still active, with at least the second one there having over 670 posts just last month still on COVID. As we use social media, we found that it was helpful not only for education, but also to be able to have contingency planning, as well as emergency preparedness. And it was actually helpful in being able to conduct research and being able to move beyond even descriptive research. After we initially got additional education from experience sharing, we were able to move on to the development of resources. Multiple different organizations formed informational websites, including SCCM, SOCA, the CDC, Health and Human Services, and local departments of public health. We were able to disseminate information such as this infographic from Italy about how they actually cared for their patients on these types of websites. So you can see here on this infographic, they were able to talk about what COVID was and how they were actually caring for their patients in the ICU. A second infographic that was shared on these types of sites was this Seattle Intensivist one-pager by Nick Mark. And we were able to have additional resources and recommendations by organizations such as the APSF and discussing how to do airway management in these patients. The Society for Critical Care Medicine even sent out infographics on ICU preparedness and how to use additional staffing in our ICUs once our ICU staffing was overwhelmed. Following the creation of informational websites, multiple organizations again were able to form databases of additional COVID research resources where you could go to find articles and things of that nature. IRS has a very nice coronavirus resource section, as does SCCM, the New England Journal of Medicine, and even PubMed has an area on its site where you can go for specific COVID-19 articles. After the creation of all of this information, we used networking to be able to disseminate the knowledge. We used a variety of different types of alternative media. Doc Matter actually has multiple different communities, including ASOCA, ASA, IARS community. We're able to discuss important issues to us, including COVID-19. There are multiple podcasts and interview sessions that were presented discussing specifically COVID-19. The Health and Human Services actually put together a national COVID-19 grand rounds that happens bi-weekly, one of which meetings are specifically for ED physicians, the other for intensivists. The World Health Organization created videos on COVID, and even Mocha Minute added additional COVID-related questions to help disseminate knowledge. Because of the overwhelming nature of the number of patients that we had coming to the ICUs and the lack of intensivists to be able to care for these patients, there was a lot of resources put into training for non-intensivists. First of which being dissemination of the SOCA ICU Residence Guide. Also, SCCM had a critical care for the non-ICU physician that included informational resources on their website, as well as webcasts and webinars. The ASA Anesthesia Intensivist Hotline was formed. This is actually a hotline designed much like our malignant hyperthermia hotline, where there's an anesthesiologist who's also an intensivist that can be reached at any point to be able to discuss how to care for an ICU patient. And finally was the CSER ICU project. The CSER ICU project was a collaboration between SOCA, the ASA, the Society for Critical Care Medicine, and Anesthesia Patient Safety Foundation. And here there was a wealth of experts who actually put together a resource library for anesthesiologists who did not have specific training in ICU. This resource library had multiple different topics, as you can see here, and information regarding each of these topics to help non-intensivists care for patients who were in the ICU if they were called to be the bedside provider for these patients. Over the course of time, we wanted there to be additional sites of data and resources that we had. At the beginning of the pandemic, what we had was typically things like news releases, where the NIH came out and talked about remdesivir. Following that, in February and March, we ended up with recommendations, experts reaching out and talking about what's likely the best thing to happen for patients regarding airway management, or caring for patients in the ICU, or managing patients perioperatively. Over the course of time, various journals actually called for additional articles related to the coronavirus. And this is such a submission that, or this is such a call that was released in early March by ANA and ANA Practice, where they were looking for a special series of articles talking about COVID-19 in a variety of different ways. They also noted that they were going to expand the scope of the letter to the editor section and also make all of their articles immediately available and free access to everyone on the website, as well as on PubMed. Other journals followed suit. And you can see here JAMA and the New England Journal of Medicine expanded their correspondence and letter to the editor sections to allow for additional experiences related to COVID to be released for people to get additional information from reputable sources. Another wealth of information that we were able to use to care for our patients was the use of pre-publication articles. ANA released a variety of articles related to COVID-19, including the management of COVID patients in the acute care hospitals. There were also articles released pre-publication on immunologic memory. There were early views, as in this article in the European Respiratory Journal, on high flow nasal cannula and bioaerosol dispersion, as well as taking care of the sedation for mechanically ventilated patients. When should we do tracheostomies? And even the first autopsy series was released as a pre-publication article. So over the course of time, networking has really helped us to be able to get early information gathering and sharing of personal experiences taking care of COVID patients. From there, we were able to develop resources on professional websites and organizational databases to be able to have sites where we could go for all of that information. Throughout this time and kind of the early stages of the epidemic, we were still able to discuss via online communities and social media. And then over the course of time, as we started to know more about this disease, we were able to work together to develop training programs for the non-intensivists and to be able to come together to do research, whether being from personal contacts or via social media, to really come up with additional articles to dispense and disseminate the information that we had learned over the course of time. So where should we use networking moving forward following the pandemic stages? I think the most important thing will be to cultivate a culture of continuous information sharing and networking. This can be done still through virtual communities such as ASOCA, IRS, or ASA Doc Matters communities, where people can come together to ask questions and share information. It can also be done via social media, i.e. Twitter and Facebook. There are multiple great opportunities for being able to use FOAM, which is free open access education, as well as using these social media sites for public education. Many different organizations, including SOCA, have developed webinars or webcasts that happen on a periodic basis. And I think being able to use these opportunities to be able to talk about different topics as they come up is something that we should continue in the future. And then one of the wonderful things that's come out of the SARS epidemic is really the use of open access or free resources for relevant information sharing based on especially new or changing disease states or pathophysiologies. So I think this would be a fantastic thing to continue as we move out and away from the pandemic. I'd also like to take this opportunity to find out what other resources you found to be helpful during the pandemic, or whether specific resources or educational offerings that you would like to see continue post-pandemic. So please feel free to use the chat to answer either of these questions below. And I want to thank everyone so much here at SOCA for allowing me to come and present and talk today.